It is my pleasure to introduce to you tonight our speaker for this evening's presentation, Dr. Tanya Atagi. Dr. Atagi is a board-certified plastic surgeon based in Lone Tree, Colorado. Dr. Atagi earned dual undergrad degrees in design and post-design engineering at Stanford University. After graduating, she worked as a biomedical engineer designing and prototyping medical devices. She was awarded a patent for one of her developments. Her biomedical engineering experience convinced her to pursue her interest in medicine. She completed a post-baccalaureate curriculum in chemistry and biology at Harvard. She then returned to Stanford, where she was accepted into medical school and received her doctorate of medicine. Realizing that plastic surgery was the perfect way to blend many of her professional interests and talents, Dr. Atagi completed an integrated residency program in plastic and reconstructive surgery at Barnes-Jewish Hospital in St. Louis. Advanced training followed, including a plastic surgery research fellowship at Washington University in St. Louis and aesthetic surgery training at Grossman Plastic Surgery in Denver. So with that, I'd like to turn things over to Dr. Atagi. Are you there?
Yes, I am.
All right, Dr. Atagi, we're going to switch things over to you. And then, there you go. Are you able to see your presentation?
Thank you.
Thank you so much for being here with us tonight, Dr. Atagi, and for taking time away from your family tonight to speak on your experience with adding an office lipo. So I'll turn it over to you.
Great. Thank you so much for having me. So my name's Tanya Atagi, and I'm a private practice plastic surgeon here in the southern Denver metro area. And I hope that you'll just indulge me for a couple of minutes in terms of my first slides, because I'm going to talk just a little bit about my practice so that I can hopefully give you a little bit of an idea of where I'm coming from and my practice perspective, since you're getting and taking some advice potentially from a person behind the curtain. So hopefully this will give you a little bit of an idea of where my thoughts are coming from. So as mentioned previously in the nice introduction, I started out as a product design engineer and completed my aesthetic fellowship training in 2002 and have been in private practice since 2003 and really a Vaser user since 2002. I had the good fortune of being introduced to the vaserlipo system since Sound Surgical Technologies is located here just north of Denver. So we had the opportunity to start with them early. Also, I'm a farmer's daughter, and the reason that I mention that is I feel that I'm pretty pragmatic as far as my engineering background and being a farmer's kid, and I'm pretty frugal with my dollars. So hopefully that will add a little bit of perspective as well. So I've been in private practice with a couple of associates, including Dr. Grossman, for 7 years, and then really in solo practice for the last 5 years. And as likely with many practices, I was primarily doing reconstructive work in the early period, and really just over the last 1 to 2 years have been transitioning into more of an aesthetic practice. And in fact, terminated all of our insurance contracts as of May 1st of this year, with the exception of Medicare and Medicaid. And, you know, as I mentioned, I'm an engineer and a plastic surgeon, not a business person. So this transition is taking place just as the economy is downturning. So obviously that's influencing all of us, including myself. So as far as my practice presently, I think that there are 3 decisions that I just happen to have made over the last year or two that have really helped to sustain my practice through this economic downturn, because I am, in fact, doing fewer surgical procedures, but really bringing in an active skincare practice, and growing our injectable practice has really been exceptionally helpful. But also in terms of my surgical practice, having the vaserlipo system available here in the office has really been a tremendous lifesaver to a large extent. Historically, my practice has really been operating room based, whether in the ambulatory surgery center or the hospital. I do not have an in-office OR suite, and really I preferred to operate under general anesthetic for most procedures, other than very simple, nevi excisions and scar revisions. I'm also, I think, very risk averse. And as far as the hassle factor, I'm pretty hassle averse. I really, probably like most people, really try to make things as simple as possible. But I tend to move with the flow as far as tried and true technologies, as opposed to really being kind of the first in town to do anything. And at this point, really, we're doing pretty minimal marketing. We've got a very nice website up, but as we've discovered, it's not particularly optimized for search engines. And the only real marketing that we're doing, other than working on our website, is geared toward our vaserlipo offering here in the office. As far as our practice, again, I've been doing the vaser in-office procedure since the beginning of May of 2008, so really just a year and a half. And it used to be, again, really 100% of any liposuction procedures, unless they were really just small little hand revisions that I might be doing for lumps and bumps, was really in the operating room under a general anesthetic, also using vaser, though, at that time. And presently, 85 to 90% of the liposuction procedures that I performed are really here in the office. The only other real in-office procedures that I perform are upper lid blepharoplasties. I don't have lasers here in the office. I don't use IV sedation here in the office. So, again, in terms of the minimal hassle factor and not having a lot of expensive technologies here in the office, I'm not somebody that has a lot of expensive equipment here other than the vaser system, which when I say expensive, we'll talk about that, but I really feel that it's a reasonable technology. My concerns as far as bringing the vaser system into the office, obviously it's a big investment for someone like me who's really just getting up and running with my aesthetic practice. And the concern was ending up with something that's going to be really acting as, a countertop in the corner. And so it did really require a lot of kind of mulling over in my own mind. Some of the concerns I had were, what is going to be the unforeseen costs? What are the things I bring the system in that are going to, catch me by surprise? And how big really is the hassle factor going to be? And the big concern was really, if I bring that equipment in here and find out that it's an unpleasant experience for both myself and the patient, that's going to be a very big headache. Safety questions in terms of using the lidocaine here in the office, what are those issues going to be, and what am I going to be doing about them, and what are the liabilities? And really those two concerns have become pretty minimal in my mind, but I also feel that we're reasonably well prepared. And I definitely had no interest in torturing patients here in the office if they're uncomfortable, because really it was going to be an equal discomfort to myself. So those are the things that I was really concerned about as far as bringing the technology in. And partly because I'm a pretty committed vaser user, so I wasn't as concerned about the technology itself, but really it was more of the issue of, what's actually going to be happening here in the office as I bring the technology in. So some of the things that I looked at the vaser system, and at that time was comparing it really most directly to smart lipo, and a lot of laser lipo systems have come out onto the market since that time, but that was really the primary player that I was looking at in terms of that versus vaser. And I found the smart lipo marketing to be exceptionally attractive. to the point where I felt that really if smart lipo was equally as effective or maybe even a touch less so than Vaser, they really had a lot of press being on Oprah and all of that. So, I thought, well, maybe it would make sense just to bring the technology on board to take advantage of the marketing piece of it. And I felt that might even be worthwhile. I did go in and see a demonstration of the smart lipo technology, and maybe this should have been obvious to me at the beginning, but I really felt that just seeing the tumescent anesthetic technique with the patient awake was really the piece of it that convinced me. It wasn't necessarily the technology so much as far as the lasers, but that as long as the patient was comfortably anesthetized with the tumescent technique, that really it wasn't going to matter whether I was using the smart lipo laser technique or the Vaser system, that it was almost the question became, are you going to pick up a knife or scissors to cut the piece of paper sort of thing, that it really depended to a large extent on, is the patient going to be comfortable awake? And so I was pretty convinced that it was doable at that point. I also looked at some of the advantages and disadvantages of each technology, and again, I'm a pretty committed Vaser user, and so I felt that that was something that I was comfortable with, but also one of the concerns that I had, particularly after speaking with the former CEO and chief scientist at Sound Surgical Technologies regarding the Vaser was that, or regarding smart lipo, was that the actual probe that they use is only 2 millimeters, and maybe the technology is different now, but really it's going to take a long time to pre-treat any abdominal areas or hip rolls or whatnot. If you're working in the face, I think that laser technology made a lot of sense. But as far as using the Vaser, I think it made more sense in terms of whole body contouring. So that was something that I gave some thought to. And also, I did look at the return on investment, and that's something that we'll talk a little bit more about. But at this point, I don't know exactly what they're charging for the laser technologies, but that's something obviously that you're going to want to look at in more detail yourselves as far as the nitty-gritty detailed information. And then also the state of the economy. So I was planning on bringing in a reasonably expensive piece of equipment as everything was still bottoming out. So that was something that was important to me as far as making sure I was comfortable with what I was doing. Again, I'm already a pretty committed Vaser user. I spoke with Bill Cimino, who was the prior CEO and chief scientist, and really convinced, again, with the ultrasound technology. I felt that it was appropriate and that it had a good track record. And I also felt that the ultrasound technology could do some things that the laser couldn't, in particular, dealing with larger volume areas. But I wasn't so convinced that the laser technology could do the same. And I think that that's borne out to be true, at least from what I'm hearing from the operating room nurses who have been in the OR with other plastic surgeons using various laser techniques, working late because it's taking a lot longer to treat larger areas. So that's something that I've been happy about in terms of my decision. And again, looking at the return on investment, we'll talk a little bit more about that. But I really did not want to be taking on an additional mortgage. I was still paying off my loan in terms of building out my own office, and didn't really want to be making that commitment. So in looking at the various laser technologies that were available in comparison to the vaserlipo technique, it was really a smaller financial commitment and risk, and really seeing a more rapid and greater return on investment, and we'll kind of look at that too. So I ended up bringing the Vaser into the office because I really felt that it increased my revenue potential. We'll look at some of the numbers in terms of what we quote our patients in going to the operating room as opposed to the office, but obviously our expense was really going to be significantly less in the office. We weren't going to be needing the service of a nurse anesthetist or an anesthesiologist. And a lot of the dollars really were going to be coming more directly into our practice, so that was obviously very attractive. And I felt that the expense was reasonable, and again, we'll look at some of those numbers as far as what the supply costs per case are. And I found that it really has increased my patient base. We have a lot of patients that are interested because the procedure can be performed in the office without the need for a general anesthetic. So patients are definitely interested. And for some of my patients that needed a little bit of revision or a little bit more contouring after abdominoplasties, it was really an affordable option in terms of revision. So I'm not having to take patients that have little lumps and bumps and contour irregularities, back to the operating room. And again, I was pretty committed to the technology to begin with. These are just some general numbers. Now, what I've been told is even though we're in Colorado, we're not in New York, we're not in LA, but that our operating room fees are relatively high as far as the surgery centers and the hospitals. So just kind of ballpark figures for abdominal liposuction, we quote on the order of $7,000 for really everything other than labs going to the operating room. So surgeon, the operating room, anesthesiologist, and a surgical assistant. And in the office, we're quoting a little bit less, but really, obviously, a lot more of those dollars are coming directly to the practice. So the surgeon room charge and surgical assistant fee is about $5,600, what we quote. And these numbers, again, are pretty general because it's really based a lot on the amount of time that I think that it's going to take to do the procedure. So I think just looking at the abdomen, the lab savings for the patients, I generally order a urinary analysis, CBC, Hep B, Hep C, and HIV. And that costs the patients about $475. So I don't order those when we're performing in-office procedures. And the supply cost, which I thought was really very reasonable and was kind of surprised at, was we're incurring about $177 charge or expense per case, and that includes really everything, down to a 27-gauge needle and all of that. So we took all of that into consideration. That includes tubing and whatnot. So all of our disposables per case on average is about $200. And from what I've heard from the Sound Surgical folks, it's about an $1,800 a month lease for the system, and the total cost of the system is about $90,000. Now, you look at that, and it's still a big number, but when I was comparing it to the smart lipo technique or some of the laser technologies, for example, they were quoting me things on the order of about $145,000 for the laser, and I've heard that it's come down a little bit more on the order of $120,000 or so. That's still a significant amount of money more for the initial system, and you have to keep in mind that that does not include the aspiration and infiltration system, so you're still having to purchase that equipment. So I think as far as the system cost for the vaserlipo at $90,000, that is all-inclusive as far as the instruments, the aspiration system, and the suctioning system. And calculating that out, if you're looking at, say, just doing the abdomen at $5,600 a case, that's 18 cases. So that's something that I felt that I could really wrap my head around as far as, I'm not trying to sell packages. I'm not trying to sell, several cases per month in order to just meet my lease requirement for a laser system. But this is 18 cases total to pay off the entire system. And you can certainly ask the Sound Surgical folks in terms of the accuracy of that, but I felt that that was a more reasonable number. And as far as expanding my patient base, who's new in my practice? I'd say men of all ages. I'm getting older gentlemen, younger guys, particularly patients interested in gynecomastia correction. And I don't know if it really tends to be more of a Colorado market, but we have lots of lean, healthy, fit citizens out there. And a lot of them really would not be interested in going to the operating room or making a big deal of the smaller areas that they're interested in contouring. So a lot of these patients really also are just not interested in going to the operating room, undergoing a general anesthetic, particularly if it's just a small amount of contouring they're talking about. So it's really opened up the patients that are interested. And we look through our numbers, and really, of all patients that are eligible for in-office vaserlipo procedures, 90% of them are electing to have the procedures performed in the office. So I think it's really expanded my patient base significantly, because these are a lot of patients that would not even be coming in to have that discussion without having the in-office awake procedure available to them. As far as marketing, I don't know if you can actually read the text on this, but the only place that we've placed any ads is something called the Rocky Mountain Sports. And it's kind of a clearinghouse and a place that people go that are looking for activities such as triathlons or biathlons or marathons, biking, mountain biking races, things like that. So it's kind of a throwaway journal. They also have a good website that you find in a lot of the athletic clubs, 24-hour fitness, places like that, that people are picking up and just kind of looking through as a throwaway newsprint item while they're working out. And we've gotten a lot of calls from this. And again, I'm not doing a lot of marketing. This is really the only area that I'm doing, even have an ad. And we're trying to target the guys in particular and people that are fit. So the ad reads, think you've tried everything, think again. Protein shakes, 5 a.m. workouts, and still pinching inches, walk in, walk out procedure, in-office or office-based procedure without ultrasound-assisted liposuction by vaser, safe, effective, convenient, private. So those are the things that people are looking for. Is it a viable, effective option? How easy is it for me in terms of recovery, the procedure itself, and being quite private about having anything done? So as far as just kind of getting started, the things that you want to look at as far as the physical plant, we have a procedure room that is very modest. It's 10.5 by 7.5 feet, and I think that space is generous, meaning when you look at the configuration as far as how we have our room set up, we have a lot of dead space that we don't really need. So I don't think that your space really even needs to be of that size. I've indicated in red the areas of counter space or tabletop space that we're using, and I think that that's generous as well. I mean, we're very comfortable with that space, and if you're efficient, I don't think that you even need that much counter space to work, but you'll see a couple of pictures, actual pictures of the room. But we also bring in our cart is a Sears Craftsman tool chest. And it's worked out very nicely. What we do is we actually keep a lot of our supplies, disposables and whatnot on that cart, and we just wheel it in when we're having a lipo procedure. So I'm sorry this looks like a messy bedroom, but this was just a photograph that I had taken for ourselves. But it looks like we are using a lot of counter space, but really just that area left of our sink is what we're using. The other stuff is really just junk. And then also the bottom right-hand corner, that's our little Craftsman cart that we wheel in, and then our Mayo. That's looking kind of into that left corner of the diagram, but that's a little bit of a close-up. And this next room photograph is looking into the other corner, and the door you're seeing is our dirty utility room. But we basically use our little Craftsman cart as our back table and then work off of the Mayo, but you could really almost work off of the Mayo as long as you're organized. Just another view. So what you want to do is obviously inventory what you've got. So what do you have and what do you need? So a lot of the things that you're seeing are really things that you're going to have already. And I feel, especially right now, be practical about what you're doing. and looking at. I mean, I looked at the secondary market. Our procedure chair I actually purchased on eBay and have been very happy with it. We have a place called Plaza Medical. It's a family that has a showroom here of really refurbished secondary equipment, and it's really like going into a candy store there. You go in there, and you can find a lot of terrific things, and they do a very good job of supporting us after they've sent the equipment out to us. So as far as more of the kind of potentially more expensive things that you might need that you may not have, procedure chair that's going to lay flat so that you can do your procedure. We had a little bit of a smaller Ritter M9 autoclave, and we just traded that out for a larger one because we needed something deeper to accommodate the cannula. So that's really the only thing that you need to check for, is to make sure that it's deep enough to be able to sterilize your cannulas and probes. And then our little auto Craftsman tool cart. Again, that's really just, I think it was $200 or something, but it's really made things very convenient because we just throw everything we need onto the cart. It gets wheeled out when we're not needing it and wheeled in when we're using it, and then a large mail stand. And as far as the Vaser equipment, you can certainly talk more to the Sound Surgical technology folks about the actual system, but you're going to get for $90,000, you're going to get the infusion system, the Vaser amplifier emulsification system, the aspiration console, and all of the instruments are included in that. And I think the only things here that you need to purchase are the skin protectors, and those are semi-disposable. Here is kind of a product order sheet of the disposable. So you can get almost everything from Sound Surgical Technologies. And that $1,026 in the bottom right-hand corner, that's really what we spent, buying one case of canisters, buying one case of infusion and suction tubing, all of that just to really get a few cases under our belts. And they also have a very nice sterile procedure pack, which is shown at the bottom, that includes drapes, laps, prep, bowls, scalpel, all of those sorts of things, and it's $40. So we bought one case of that to get us started. We thought, well, maybe if we could save some extra dollars, we could put our own kits together. But this is a beautiful kit. I mean, you open it up, it has everything that you need from that standpoint. Also, just a couple things. I mean, you're going to have all of this in your office: needle drivers, suture scissors, forceps, hemostat, towel clips. I did purchase a pickle fork, which I don't really know what the technical term is for it, but I use it to break up some adhesions. And so I really just, again, wanted to kind of list all of the different things that you could potentially need, just so that you don't end up kind of having to spend a lot of extra for things that you didn't really think of. And also, this may be a little bit silly, but if you're not doing a lot of procedures in the office, you're potentially going to need some sheets and blankets and pillows to keep your patients comfortable. And we use a baby monitor, which has been great in terms of just having that in the room. Obviously, you have to be careful in terms of where you've got the other end of the monitor as far as HIPAA, because you are, speaking to your patients and whatnot during the case. But we found it to be very helpful, because if you are a surgeon working without an assistant, just, calling out and letting somebody know that you need something open can be invaluable as far as saving time. So we found that to be just a cute little trick that helps to move things along. Things like a little fan, water, straws, crackers. Because your patients are awake, sometimes they'll get a little queasy and whatnot, or a little hot, and having these things can really just help to make the case move along. So you're not having to stop because someone's potentially not feeling well or a little bit warm. As far as the safety issue, we did not really have any of these things in our office. Again, we were only doing things like little scar revisions and removing moles. But my sense about it was, in terms of a liability issue, we wanted to feel that we were very prepared in case something were to happen. And as far as an AED, they're not that expensive, and I felt that, you can get an AED in the mall. And so I felt that, that's something, even if we weren't going to be moving into doing more procedures in the office, would be important to have. And in fact, the day after we got our AED, a patient went down in the foyer of the office building, and so the gang here in the office grabbed the oxygen tank and all of that in the AED and took it out there. So that just kind of solidified in my mind that it was something, an expense that was well justified. And as far as this emergency stuff, again, we just keep it on our cart. You know, you see the AED, the oxygen, the ambo bag, all of that on that bottom shelf, so it's very easy to access. And also it's something, you know, really if we need to take it out into the hall for whatever unforeseen circumstance, you know, it's very easy to be able to do that. And we do have things like Narcan, Epi, Benadryl, ammonia salts, and Zofran here in the office now, just for you know, if nothing else, help us feel better. As far as just making things easy for yourself, I got this nice conversion chart from Dr. John Millard, who's a big proponent and user of vaserlipo. Basically, it gives us 35 milligram per kilogram, 40 milligram, 50, 60, 75, 80 across the top. And then the patient's weight in both kilograms and pounds down the left side. So really all we do, if we want to stay in that 35 to 40 milligram per kilogram zone with the lidocaine, we just look that up relative to the patient's weight. So that gives us an idea of what we're going to be working with as far as preparing our tumescent bags. And then at the bottom, there's some suggestions in terms of the female abdomen, the male abdomen, how much, what are the concentrations and how many liters are we potentially going to be using. So that's a nice kind of guideline when you're first starting out. As far as staffing, really, if you have a warm body in the office somewhere and a baby monitor and you as a surgeon are operating, that's really doable. But I think from, again, a safety standpoint, it's nice to have two other people available in case you have some sort of an event. You'll have help. But really, I've been more and more comfortable. Our patients are awake. They're talking to us, and we've done very well from that standpoint. So I've been much more comfortable from that safety standpoint. And I actually have the luxury of having an RNFA here in the office who is my assistant in the operating room. So she's terrific in terms of actually being able to help out actively during cases. As far as patient selection, what I'm looking for is a patient that's interested in the awake procedure, somebody that's motivated to be actively participatory in the program as far as helping out. And, you know, really working on smaller areas. I'm not going to be doing any large debulking procedures in the office. And if we're looking at fewer areas, someone that's not particularly squeamish and of even temperament. And I think that some of those same guidelines go or apply to us as surgeons as far as you know, are you going to be somebody that's going to do well bringing this technology and this type of awake procedure into the office? I mean, you've got to be motivated and interested in dealing with an awake patient. I think that if you're of even temperament, that's definitely going to be helpful. And I think there's a real financial incentive for both the surgeon and the patient as far as the patient's going to be paying less in terms of not going to the OR and all of that, and more of those dollars are going to be coming to your own practice. What's doable as far as anatomically? I think really any anatomical area is doable in the office. Again, we're talking mostly about patients that are relatively fit, pretty close to their ideal body weight, and we're really treating smaller volumes and fewer areas. What's and who's doable? Again, the kinds of times that we're looking at, I find that I'm not interested in doing much above 6 hours, and that's sort of a long time. But to keep in mind, you know, if we're doing a neck or something like that, often it takes about an hour and a half, and the 6 hours is really the in-room time to the time the patient walks out of the office, and that includes if we're doing work both posteriorly and anteriorly, that's going to include a 30-minute break. You know, we get the patient up, let them walk around a little bit, stretch, have something to eat, some crackers, go to the bathroom, turning them, redraping, all of that. So as far as that 6 hours, you know, it's not complete just, you know, with your head down working time, but it's that patient time in the office. And ideally, I don't really like to do much more than or many more than about 3 areas. And certainly when you're starting out, you may want to just limit things to the abdomen, for example. And I'm really more comfortable working in the 35 to 40 milligram per kilogram range. I mean, certainly I've heard anecdotally people going into larger or greater concentrations, but as far as being in the office and whatnot, I'm very comfortable in this range. And I also have a pretty frank discussion with the patients, especially if they're wanting to do several areas, that really will do what we can, but our limit is going to be the amount of lidocaine that we're using. And so if the patient's wanting to do several areas and they're starting to get uncomfortable, we're using more and more lidocaine, then I tell patients, we really just need to decide that if we're starting to get into that higher lidocaine concentration range, that we're going to limit the amount of work that we're going to be doing. As far as the kind of times that we schedule, initially I was scheduling a lot of extra time, and you're going to want to do that just so that you're comfortable with what you're with the time you have available. But I found that although we are going somewhat slower as far as the tumescent numbing anesthetic portion of it, that as far as the real time, I don't know that it's really that much less time than what we use in the operating room. Plus you're cutting out that time where you're waiting to get the patient back and to sleep and all of that. So these are just some general kind of times that I use here in the office. And again, we do give the patients a break in turn and when we're turning and redraping. As far as medications, this is something that maybe many of you who do a lot of in-office procedures have worked out very nicely, but I started out with Valium, and I found that I was not particularly happy with it because I felt that it took a long time to kick in, and that by the time the patient was done and getting ready to go home, that's sort of when they were starting to really feel the maximal effects of the Valium, and I just felt that the Ativan lasts a little bit longer than I like. Again, Dr. John Millard, who practices nearby and is a very experienced vaser user, recommended Halcyon 0.25. So we just start with that, and generally either 2 Norco or 2 Percocets, and that seems to work very nicely. For whatever reason, the Halcyon seems to kick in pretty quickly. By the time we're done with one side, the patient is ready for another Halcyon, or they're ready to go home if we're only doing one side. So that seems to, for whatever reason, work very beautifully, and he feels that it seems to help decrease some of the fascial discomfort. So that's been a real nice little trick. As far as narcotic options, really whatever it is that you like to use. But we start off with the Halcyon, 2 of the Norco or Percocet, and then redose that in 3 to 4 hours, depending on whether we're turning and doing additional work. And as far as the tumescence, again, that 35 to 45 milligram per kilogram range, we're going to be using 800 to 1,500 milligrams per liter. So again, in terms of estimating how many liters you're going to be using as far as your tumescence, is going to help you to decide whether you're going to be on the lower or upper end of that. But something that I found is that using a higher concentration of lidocaine in your tumescent is not always helpful, meaning I found that the patients tolerate the tumescent portion of the procedure very nicely, and surprisingly so. What I've found that has been bothersome to me is that there seem to be 1 or 2 little recalcitrant areas where I actually just go in and use, drop a full concentration of 1% lidocaine with epi and inject directly into that area, and that seems to be helpful because in the past I've been, just really adding more and more tumescent to an area that was particularly sensitive for a patient, and it wasn't necessarily helpful. So that's something that I've been doing that seems to work nicely. And then I use 1 amp of epi per liter, and then bicarbonate, which I'm not necessarily convinced is helpful, but I do throw that in there. My first case, and I think this is going to be maybe obvious, but I selected an existing patient who was very loyal and committed to our practice. She had previously undergone liposuction, so she, kind of knew what to expect before and after, and then an abdominoplasty. And she had the lipo done by another surgeon, of course. It's not going to be me that needs the touch-up. But she had just a couple areas, a hip roll, inner thighs. They were small areas. Again, she was a pretty lean patient. And so she was my first patient. And my second case, again, an existing patient. She had undergone prior lipo procedures and abdominoplasty, and really we were correcting a little bit of lateral fullness and a little bit of anterior additional contouring. Single area, relatively small volume, so that was pretty manageable as a second case. And our third patient, again, existing patient, had previous lipo and abdominoplasty. We're going in and doing some secondary abdominal contouring, single area, relatively small volume. So these patients did very nicely, made me feel comfortable, and also our third patient, I mean, I don't quote her to other patients, but she literally said to me, that was like going to the spa. She did very well. So that convinced me to, move forward. As far as kind of the way our procedure runs, we do recommend that people have a light meal or something in their stomach just to prevent any nausea from their narcotics and whatnot. We usually have them go ahead and sign their consent, and I mark them before administering sedation. But if they've been in the office previously and signed a consent at a pre-op visit, I'm comfortable going ahead, giving them their PO sedative and their narcotics, and then marking, because that gives us a little bit more time for the medication to kick in. We go ahead and prep and begin the procedure. So really, by the time all of that ends up happening, I feel that the medications are starting to kick in. And I think as far as advice, really take your time and give yourself and your patient a lot of time during the procedure, especially for your initial venture into this. And, really you do have an awake patient, so, you've got to break out that bedside manner. And it's really been surprisingly nice, because I think that our patients feel even more comfortable with us, because it's not just an initial consultation in a meeting or two, but really we're talking back and forth and get to know our patients very well. So that's been a nice actual side benefit. And that's coming from someone like me who is used to doing everything under a general anesthetic and not, just kind of being able to go to town on the patient without having to have a lot of nice rapport with them. But I've been pleasantly surprised. Again, just kind of to start wrapping things up, general thoughts, the thing that's bothered me the most about this is the zingers, because if patients get these, they can be very uncomfortable, and I found, again, they're not necessarily adding more to Mesonat, although I will do that. Just injecting straight up local to the problem area seems to be very helpful in terms of quieting that down. And also, just adjusting your mindset to the fact that you are interacting with an awake patient, and slowing down certainly for those initial cases. As far as, you certainly have these types of things in your office, but it is helpful to have a procedure record in terms of the amount of tumescent fluid that you're using, the amount of ultrasound time, the volume you're removing. I do try to treat it a little bit more like the operating room, as far as, putting down what the expiration dates are, the medications that we're using and things like that. There is a little bit of a hassle factor, but if you organize yourself in some fashion, making sure you get the weight and vitals on the patient before you get started can certainly be helpful. And then on the right, we do have an EMR system, and it's the liposuction procedure is in a template form. So the notes from this really are very, very minimal. You're not having to dictate a long procedure note. So that seems to work out very nicely. As far as just my feeling about it, yes, it's most definitely been worth bringing the technology into the office. Doing liposuction, if you're a surgeon that's already doing liposuction, it's already an integral part of your practice, and really you're not bringing in a new procedure. You're just giving yourself the opportunity to keep more of those dollars in-house. So that's helpful. And again, as a reminder, I don't have a lot of lasers and things like that here in the office. It's definitely expanded the patient base for me. A lot more patients interested, a lot of different patients. And also it's a nice, again, touch-up option where you're not having to take patients back to the operating room for small procedures. So I think that's a nice benefit. And in all honesty, I've been very pleasantly surprised bringing it into the office, and patient satisfaction has been very, very high. I'm just throwing in a picture. I've only got the one, but I really didn't want to focus so much on my before and after photographs. But this is someone who underwent vaser lipo to the neck, and got a very, I think, nice result. Just to throw one of my before and after pictures in there. And that's it. Thank you so much for listening, and hopefully this has been helpful to you.
Okay. Dr. Toggy, can you hear me okay?
Sure.
Perfect. Okay. So we do have some questions that I'm going to ask you right now.
Terrific.
One of the big ones is how large of a patient have you treated or will treat in your office, and what's the largest fat volume you've removed?
It's been about 3 liters, 3.5 liters.
Okay.
Mm-hmm.
Now, did you get trained anywhere to do tumescent technique in office?
No, again, have been using the vaserlipo technique since it came out, and I watched someone do the awake technique, and that was a smart lipo demonstration. But I did find that very helpful, just in terms of watching somebody else anesthetizing an awake patient. And you're going to develop your own techniques, but that was very helpful. And as far as the vaser technology and technique in and of itself, if you are someone that's familiar even with standard tumescent and liposuction technique, I think maybe just watching someone once can be very helpful. And I know that you folks at Sound Surgical are very good in terms of training and whatnot. So, certainly like anything else, watching somebody do it even once can be helpful, particularly if you're familiar with the liposuction technique.
Now, do you do any other combination procedures in office when you're doing the vaser lipo in office?
I'll occasionally do scar revisions. If I have someone that's had an abdominoplasty, I'm doing a little bit more contouring and they need some scar revising, or say some breast revision or something like that, I will do that. But again, as far as in-office procedures, I don't really do a lot of things other than upper lid blepharoplasties as far as, full-on surgical procedures.
Gotcha. And then let's see what else. Did you have to get your office accredited at all to do the in-office lipo procedure?
I didn't, and that's part of the advantage of doing it awake is really our sedation is the halcyon, 1 or 2 tablets, depending on how long the procedure is, and then 2 to 4 tablets as far as Percocet, Norco, that sort of thing. I know other people may like more sedation in their patients and may be interested in using IV sedation, but I'm more comfortable really being able to monitor the patient because they're awake. So I haven't had to undergo the accreditation because really we're not doing even any any deep anesthetizing of any sort.
And then what do you do if you have a patient that becomes very uncomfortable and squeamish during the procedure?
I've had the good fortune of that not happening, and I think that a lot of it, as far as being proactive up front, is being pretty comfortable with the patients that you're bringing in to do that. But we do things like just going slowly. Talking to the patient. If they're getting queasy or something, we give them a little Zofran. We'll take a break and let them have some crackers and some water and that sort of thing. And they don't even really need to get up from their sterile prep to do that. And so maybe I've just been fortunate. But also, if you're going slowly, you're taking your time with the tumescence and getting good anesthesia, the patients seem to do very well with that. So I haven't really had to deal with that per se, but if somebody's getting uncomfortable, it's just sort of treating that as it goes and taking your time about it.
And then I don't know how much experience you'd have to answer this question, but a doctor is already doing PAL awake and traditional liposuction. This seems as an easy transition. Can you be as aggressive as you would be as if you put somebody under general anesthesia?
I think that you can, and a lot of that again has to do with the tumescent anesthetic portion of it. But at the same time, I'm pretty conservative again in terms of the hassle factor and those sorts of things in the office. I generally am not going to bring in a patient where I feel that I really am doing a lot of work, a lot of volume, a lot of different areas. I just take those patients to the operating room because I don't want to be in that position where I feel that I can't be as aggressive as I need to be, particularly in a larger volume patient. So I'm really bringing in patients that just need, some sculpting and contouring in smaller areas.
See, I have a couple more questions for you. Okay.
Sure.
Do you do any fat transfer with the Vaser Fat, and if so, do you do it in the office?
I don't. That's something that I'm looking at. I've just found in the past, in my hands, I haven't been really very happy with the fat transfer, but that's an excellent point because I understand that the Vaser has a system where you can sterilely trap the fat, and with the emulsification technique where you have viable fat cells that are very you're not getting a lot of tumescent fluid back. A lot of times you're not even getting a lot of hemorrhage. You're getting that nice, creamy, milky fat coming back. And I know that surgeons have done studies on that fat showing that it's quite viable. I think the Vaser is terrific for that opportunity in terms of harvesting that fat and using it in the office. I think it's going to be really great for that.
Let's see. One of the questions I have, sorry, I've got quite a bit of questions coming in. Do you do any superficial lipo in office?
I do. And in terms of patients' comfort level and whatnot, it works out, very nicely. So yes, I do.
And are you leaving drains in and closing the incisions?
I don't generally use drains. I do use compression garments, and I think that people would argue that they don't necessarily help with seroma. Some people feel that they do. I just think in terms of patient comfort and support and helping with some of the postoperative edema, that the garments are very helpful. And so I don't really. I've never actually had to use drains. I'm sure that I've just jinxed myself by saying that, but I haven't had to, and I don't generally tend to. But as far as what I'm doing in the office, again, we're not doing a lot of the large volume work in the office, so I don't feel that that's necessary. And as far as closing the incisions, I do close my incisions. I know that some people don't, but I feel that the incisions heal nicer. It's a little bit tidier. And just as far as for the patient, just yucky factor, I've had a couple of patients that have gotten up to, or one patient actually that has gotten up to go to the restroom when we flipped her over from one side to the other. And I had closed her incisions and she had sprung a leak, and it was very messy. And so just from a tidiness standpoint, as far as your own office and also getting the patient home comfortably and whatnot, I'll often send them with checks in case they develop a little bit of drainage or a leak or, and whatnot, just to protect their car. But from a practical standpoint, if it were me, I would not want to go home draining because, as you know, even the smallest amount of drainage looks like a lot and can make a very big mess. So, just from a practical standpoint, I do close my incisions.
Sure. No, I think those are all good tips. Well, I think that you have answered all the questions tonight, unless somebody's thinking of something to get it in quickly. But I really want to thank you tonight for speaking for us and sharing with everybody your experience and the decision-making process that you went through. And you have a lot of really great tips and tricks for making it a little bit easier on yourself and hopefully others.
Well, thank you so much. Thanks for having me.
Yeah, and I think that's it. Have a fabulous night, and thank you, everybody, for joining us.
All right. Yes. Thank you, everyone. Good night.